Good evening, participants and delegates, and all the delegates who are joined to Shield Connect. And we are back with our series Icons in the Conversation with Dr. Ritu, sponsored by Dr. Ritu Sanpani. And today we have a famous doctor from Bangladesh, Dr. Kamrun Nahar. So the icon for the day is Dr. Kamrun Nahar, and ma'am is going to take topic recurrent pregnancy loss. So before we start with the session, let me give a quick introduction of Dr. Ritu Santwani. Ma'am has done MBBS, MD, FICOG, FIOG, MARCOG, ERT from Singapore. Ma'am is obstetrician and gynecologist, sexologist, cosmetologist, and infertility specialist. Ma'am is founder and CEO of 360-degree Healthcare Studio in Goregaon, Pune. And ma'am is director of Shamwell Women Clinic and PTBC. And ma'am also co-founder of MAAM, board member of WSCG. And now let me introduce our icon of the day, Dr. Kamrun Nahar. Ma'am has done MBBS, DGO, MS in Gynec and Obstetrics, associate member of Royal College of London, WHO Fellow Singapore, laparoscopy and hysteroscopy surgeon, infertility specialist, special training on cosmetogynecology, consultant gynecologist, and infertility specialist. Currently, ma'am is practicing in Popular Diagnostic Center in Narayanganj branch in Bangladesh. And previously, ma'am has achieved her MBBS from Dhaka University. She obtained MS and DGO from same institute. She has 21 years of vast experience in field of obstetric and gynecology. She is trained in infertility and reproductive health from Mount Elizabeth Hospital, Singapore and Chennai. She also trained in laparoscopic surgery from BSMMU, BIRDEM, OGSB. More than she obtained special training on cosmetic gynecology from New Delhi. Throughout her career, she has developed her skills in modern gynecology, obstetric and infertility management. So I welcome Dr. Kamrun Nahar for today's speak on recurrent pregnancy loss, and I will hand over the session to Dr. Ritu Santwani. Thank you so much.
Yeah. So thank you, Nishan. Thank you so much. And thank you, Shield Connect, for providing us the platform. So knowledge always increases by sharing. The more we share the knowledge, the more we learn. So this is the motto of the starting of this program, mine. This program is very well appreciated by all across the globe. So welcome all my dear friends who have joined all across the geography. I'm able to see some friends have joined from Nigeria and some from Karyo and some from Saudi countries and some from, of course, from the Bangladesh and our India too. So today with us, a very, very special guest, Dr. Kamrun Nahar, madam. Madam, a very, very warm welcome from our side. We can say salam and good evening to you, ma'am. And we are very much grateful to you that in spite of your being very busy schedule, you have accepted my invitation. So friends, today madam is going to discuss with us a very important topic, the recurrent pregnancy loss. Whether we are obstetrician or infertility specialist, each and every one of us are getting the patients of the recurrent pregnancy loss in our OPD. And there's a lot of dilemma in the everyone's mind. So what to give, what not to give, and there's so much recent advancement. When to start the aspirin and when to stop the aspirin, till when you have to give the progesterone and when you want to give the steroid and when you have to go start for the induction of the labor. Besides that, there are so many concepts and new concepts are coming for the etiology also, whether we have to go for the torch testing for the recurrent pregnancy loss, yes or no. What about the SLE? And besides that, there are so many other things are there. So today, madam is going to discuss with us. This is very, very important topic. So once again, a very, very warm welcome, dear madam, in my show. So now I'm handing over the session to the madam. Friends, the program is going live on the YouTube. So those you have any queries, please put the questions in the chat box. Just after this finishing the madam's talk, we will take that questions. Once again, welcome to all of you on this very executive program. Yeah, over to you, ma'am.
Thank you. Thank you very much, Dr. Ritu, for your kind invitation and kind words for me. Actually, I feel very honored to be the part of your program. And every time, whenever I watch your program, it was so wonderful. And again, thank you for inviting me for your program. So we are going to the main schedule. Should I go to share my screen?
Yes, ma'am. Yes, ma'am, please.
Am I audible?
Yes, ma'am. Loud and clear. Yeah.
Okay, thank you. Okay, today we are going to talk about the very important and distressing topic which bothers a lot to the mother, to the father, and whole family, which is recurrent pregnancy loss. The loss of pregnancy at any stage can be a devastating experience, and particular sensitivity is required in assessing and counseling for recurrent miscarriages. Miscarriage is a term which brings lots of sadness to any family, and miscarriage is loss of life in a very early stage of pregnancy. It is emotionally traumatic, similar to stillbirth or neonatal death. So, what is the definition? 3 consecutive losses of clinically recognized pregnancy is less than 20-week gestation or less than 500 grams. Ectopic, molar, and biochemical pregnancies not included. Now, everyone knows the types. There are primary RPL, secondary RPL, and tertiary RPL. When we call the RPL is primary, those women who have never had a previous live birth is called primary RPL. And the secondary RPL is women with previous history of delivery beyond 20 weeks and then suffer subsequent losses. Now, the tertiary RPL defined as women who suffered multiple miscarriages interspersed with normal pregnancies. What is the incidence? Actually, more than 50% conceptors are mostly unrecognized. Though the 10 to 15% of recognized pregnancy are lost, including 90% of these before 12 to 14 weeks. 10 to 20% of pregnant women have sporadic spontaneous abortion, 2% have 2 consecutive spontaneous abortion, and 0.41% have 3 consecutive spontaneous abortion. There is so many dilemma. When to start the investigation? Actually, no specific number of criteria that justify evaluation of RPL, which define the scope of investigation, usually 3 or more pregnancy loss, but ACOG recognized 2 or more pregnancy losses, then we go for investigation. As the risk of recurrent loss is fairly high after 2 losses, investigate after 2 losses if female partner more than 35 years, there is infertility, fetal heart activity observed in any of pregnancy losses, and normal karyotype of conceptus. Now, sometimes we think how to investigate, where to start. Actually, investigations done most commonly treated causes first, then going for others. Do not order a blood screening. So we take detailed history first and clarify and documented the RPL. Take history about the recurrent spontaneous abortion, if there is any chemical pregnancy loss, if the woman have early pregnancy loss less than 8 weeks or more than 8 weeks, if there is any second trimester abortion, or she had stillbirth. We take detailed past obstetric history also, like if she have any full-term birth, premature birth, if she have had any malformed fetus, which time of pregnancy she had abortion, and there is any location of fetal heartbeat present during the abortion. Also, we take the history of risk factor. 50% of causes can be, though we know the 50% of cause can be determined. So the etiological categories are uterine factor, immunological factor, endocrine, genetic factor, thrombophytic, environmental, and unknown. Now we are discuss about the anatomical factor or uterine factor. Congenital uterine anomalies are present in 4.3%, which ranges from 2.77 to 16.77%. Usually late miscarriages, that is second trimester, due to associated cervical weakness. Women with septate uterus are most likely to miscarry in the first trimester. There are various reasons for abnormal implantation, like decreased vascularity in case of septate uterus. There is increased inflammation in the uterus due to fibroid, and there is sometimes decreased sensitivity to steroid hormone. Other causes include endometrial polyp, uterine synecdoche. How can we assess the uterine factor? First of all, we are going for sonohysterography, which is more accurate than hysterosalpingogram. It differentiates septate uterus from bicornuate uterus. We also go for hysterosalpingogram, but this hysterosalpingogram does not evaluate the outer horn. We are going for hysteroscopy, which is gold standard both for diagnosis as well as treatment of intrauterine lesion. We are going for 3D ultrasound, which give the presence and location of uterine myomas, and also give idea about the associated renal anomalies. Last of all, we are going for MRI, which differentiates septate uterus from bicornuate uterus. Now, what treatment should I go for? Actually, hysteroscopy, I told before, this is the gold standard and procedure of choice for both diagnosis and treatment. We go for laparoscopic myomectomy for fibroids, and last but not the least, for laparotomy. Let us talk about the endocrine causes. Most common endocrine causes are diabetes with HbA1c in the first trimester at risk of miscarriage and fetal malformation. But well-controlled diabetes mellitus and thyroid is not a risk factor for recurrent pregnancy loss. Polycystic ovarian syndrome, which is commonly seen in our day-to-day practice, has been linked to an increased risk of miscarriage. Exact mechanism unclear, but increased risk has been attributed to insulin resistance, hyperinsulinemia, and hyperandrogenemia. An elevated free androgen index appears to be a prognostic factor for a subsequent miscarriage in women with recurrent miscarriage. Thyroid antibody. Presence of thyroid antibody in euthyroid women with a history of recurrent miscarriage does not affect future pregnancy outcome. The presence of antithyroid antibody, that is thyroglobulin and thyroid peroxidase, may represent a generalized autoimmune abnormality, which could be a contributing factor in miscarriages. Screening for thyroid disease is not useful unless the patient is asymptomatic. Now, the common endocrine cause, luteal phase defect. Progesterone is essential for implantation and maintenance of pregnancy, or we know, but a defect in corpus luteum causes impaired progesterone production. However, luteal phase defect cannot be diagnosed during pregnancy. A consistently short luteal phase duration is the most reliable diagnostic criteria for recurrent pregnancy loss. Now, we are going for the most important genetic factor. 50 to 70% spontaneous miscarriages occurs due to chromosomal abnormality, that is the first trimester losses. Trisomic miscarriage does not increase the risk of subsequent miscarriage. Structural chromosomal defect, about 2 to 5% couple with recurrent pregnancy loss, and the most common are balance or Robertsonian translocation, which is most frequent in female partner. Individuals with balanced chromosomal rearrangement are usually phenotypically normal and are at the risk of having conceptus with normal, balanced, or unbalanced. Chances of subsequent miscarriage are higher, 50% compared to non-carrier couple with recurrent pregnancy loss is 30%. Now, what is the importance of karyotyping? Karyotyping is the very, very important, and it is recommended by RCOG Green Top number 17. And the parental karyotyping is done when couple is at risk of being carrier, if the karyotype of product of conception reveals unbalanced structural defect, and American Society of Reproductive Medicine suggests in all cases of RPL chromosomal analysis of both parents during their initial evaluation. So what is the advice? Actually, genetic counseling, proper counseling is given for those people are suffering from genetic causes. Assisted reproductive technology, including pre-implantation genetic diagnosis done before assisted reproductive technique. And these are used in either donor oocyte or donor sperm, depending upon the affected partner. Let us talk about the autoimmune factor. Most common autoimmune factors are systemic lupus erythematosus and antiphospholipid syndrome. Risk for loss is 20% mostly in second and third trimester of pregnancy and associated with antiphospholipid antibodies. 5 to 50% women recurrent pregnancy loss may have antiphospholipid antibody. Antiphospholipid antibody likely induce microthrombi at placenta site, thus altered vascularity, affect the developing embryo, ultimate cause abortion. International consensus classification criteria are antiphospholipid syndrome is present if one of the following clinical criteria and laboratory criteria are met clinical criteria. Thrombosis, one or more, equal to one confirmed episode of venous, arterial, or small vessel disease. One or more unexplained death of morphological normal fetuses after 10th week. 3 or more unexplained consecutive spontaneous abortion less than 30 weeks without maternal, anatomic, or hormonal abnormalities. And paternal and maternal causes are excluded. Premature birth less than 34 weeks associated with severe preeclampsia or placental insufficiency. What are the laboratory criteria? Anti-cardiolipin assay, IgG or IgM antibody, lupus anticoagulant, anti-beta-2 glycoprotein antibody, IgG or IgM, if 15 to 20 unit, then it is low positive. If it is 20 to 40 unit, then it is moderately positive. If the IgG or IgM is more than 40 unit per ml, it is highly positive. To diagnose antiphospholipid antibody syndrome, 2 positive tests for either lupus anticoagulant or anti-cardiolipin antibodies of IgG and IgM plus in medium or high titer over 40 unit per ml or above percentile, 99th percentile at 12 week apart are most diagnostic. So, what is the treatment? All of we know the treatment is aspirin and heparin. Aspirin 75 to 100 milligram per day given preconceptionally, and heparin 5,000 to 10,000 units subcutaneously BD. Mostly unfractionated heparin begin at the first indication of pregnancy. And there is no need to monitor the platelet count because there is no risk of osteoporosis. We give low molecular weight heparin, which is equally beneficial. Once daily administered, either enoxaparin 1 milligram per kg body weight. And when should we stop the aspirin? It is stopped by 34 days. And in case of planned delivery, stop the unfractionated heparin 6 hours before delivery. And in case of low molecular weight heparin, stop it before 12 hours of delivery. Now we are going to the immunotherapy. Progesterone is called natural immunosuppressant due to inhibition of immunocell at maternal fetal interface. What's the mechanism? Mechanism is progesterone inhibit the T helpers 1 immunity and shift the Th1 to Th2 type responses. No verification yet through RCT. It is safe and inexpensive. Doses of progesterone is 100 milligram BID vaginal suppository, and it should be begun 3 days after ovulation. Thrombophilia. The potential association between the RPL and heritable thrombophilia is based on the theory that impaired placental development and function secondary to venous arterial thrombosis would lead to miscarriages. So women with heritable or acquired thrombophilia disorder have significantly risk of pregnancy loss, increased factors 7, factor 8, factor 10 fibrinogen, but no increase in naturally occurring anticoagulant, that is antithrombin 3, protein C, protein S. Protein S level decreases by 40 to 50%, while antithrombin 3 and protein C level remain constant. What are the most common inherited thrombophilias? Activated protein C resistant, factor 5 latent gene mutation, which are common inherited factor. Also, hyperhomocystinemia and prothrombin gene mutation. And most common acquired thrombophilias are antiphospholipid antibody, activated protein C resistant, hyperhomocystinemia. Other possible abnormalities are deficiency of protein C, protein S, and deficiency of antithrombin 3. But ACG does not recommend in the first trimester loss, women with second trimester miscarriage should be screened for inherited thrombophilias, including factor 5 latent, factor 2 gene mutation, and protein S. Now, the treatment of inherited or acquired thrombophilias. Again, we are going for unfractionated standard heparin, either therapeutic doses or prophylactic doses, and we should monitor the activated partial thromboplastin time. And therapeutic doses are 10,000 to 50,000 every 8 to 12 hours. And APTT must be within 1.5 to 2.5. Either low molecular weight heparin, we go for enoxaparin, 40 to 80 milligram subcutaneous BD, or dalteparin, 5,000 to 10,000 unit subcutaneously BD. Now, the environmental factor. There is some confirmed association with environment and recurrent pregnancy loss. These are ionizing radiation, organic solvents, alcohol, mercury, lead. And suspected association are caffeine, who consume more than 300 milligram per day, cigarette smoking, obesity. And there are some unknown association. These are pesticides. Maternal cigarette smoking and caffeine consumption have been associated with an increased risk of spontaneous miscarriage in a dose-dependent manner. Secondhand smoke, which increase the risk of RPL, is about 1.5 to 2.8%. Alcohol use increases 4.84%, and caffeine use more than 200 milligram per day, which increase the risk about 1.54 to 3.85%. Now we are going lifestyle modification. Only lifestyle modification we can give the successful pregnancy. In the male partner, it is suggested to assess lifestyle factors like smoking, alcohol consumption, exercise pattern, and body weight. Obesity has also been shown to be associated with an increased risk of RPL in women who conceive naturally. Couples with RPL should be informed that maternal obesity or being significantly underweight is associated with obstetric complication and would have a negative impact on their chances of a live birth and on their general health. Also. In fact, unexplained pregnancy loss explanation despite extensive evaluation. In fact, the most effective therapy for patients with unexplained RPL is often the most simple: antenatal counseling and psychological support. These measures have been shown to have subsequent pregnancy success rate of 80% when compared with success rate of 33% in women provided no additional antenatal care. The use of empirical therapy in women with unexplained recurrent miscarriage is unnecessary and should be resisted. However, the prognosis worsened with increasing maternal age and the number of miscarriages. What is the prognosis? Although the diagnosis of recurrent pregnancy loss can be quite devastating, it can be helpful for the physician and patient to keep in mind the relatively high likelihood that the next pregnancy will be successful. A particular individual prognosis will depend on both the underlying cause for pregnancy losses and the number of prior losses, correction of endocrine disorder, antiphospholipid antibody, and anatomic anomalies enjoy the highest success rate, approximately 60 to 90%. Patients with cytogenic basis for loss experience a wide range of success, 20% to 80%, that depend on the type of abnormality present. Overall, the prognosis of RPL is encouraging. Even with the diagnosis of RPL and as many as 4 to 5 prior losses, a patient is more likely to carry her next pregnancy to term than to have another loss. So we are ending the our topic. Early pregnancy loss is a frustrating entity of both patient and providers. Understanding the potential underlying mechanism of loss facilitates cost-effective evaluation and therapy. Empathetic supportive care is in unexplained recurrent pregnancy loss, which decrease the emotional stress, increase the possibility of successful outcome. Recurrent pregnancy loss does not mean the end of an obstetric career for any couple. If proper workup under good care of an obstetrician can be done, pregnancy can be successful even after 3 consecutive abortions or more. Only important thing for the couple is to seek advice timely and to get all the investigation done before moving into the next pregnancy so that the successful outcome is achieved. Thank you. Thank you,
madam, for such a crystal clear presentation. You have. What happened? Yeah. Thank you, madam, for such a very excellent lecture. You have cleared so many points. So, friends, now we are open for the discussion. If any questions, madam has rightly pointed out the role of lifestyle. These days, so many patients are coming, in which the lifestyle also plays a very, very important role. Especially here, I want to focus, as madam has already mentioned in the presentation, the role of caffeine. The young girls are coming with a history of recurrent abortion. They are saying, no, we are not addicted to tea and coffee, but they are addicted to Diet Coke. Diet Coke is having much more caffeine compared to this normal tea and coffee. So thank you very much, madam, for such a nice lecture. Nishant, is there any questions you have received? Are you able to see?
Yes, ma'am. So we can see 2 questions we have received from chat box. Dr. Chinwe Igwilo has one question.
I'm not able to see actually. Please take the questions if you're able to.
Yes, ma'am. Can diabetes mellitus be a contributory factor in RPL?
Thank you for nice question. Yes, it is contributed factor, but if the diabetes mellitus is well controlled, if the HbA1c is well controlled before 3 months of pregnancy, if one couple is decided to conceive, so we advise them to control her diabetes well controlled before 3 months of pregnancy. After that, she can take her pregnancy. So the successful is coming up.
And the second question we received is from Dr. Vijita Reddy. When to do APLA?
Actually, if the patient coming in first time pregnancy loss, at least 2 pregnancy losses in first trimester, less than 10 weeks of pregnancy, then we are going for APLA testing or suggest for APLA testing.
Yeah.
Thank you, ma'am, for
Thank you.
giving.
Yeah. Thank you, madam. Thank you so much. I think we are not having any more questions.
Yes, ma'am.
Yeah. Let me check on the YouTube. Yeah.
Yes, ma'am.
Madam, till we are looking for the questions. Madam, my show name is the Icons in Conversation with Dr. Ritu. So now we have covered the academic portion. Now there is some non-academic questions. We all want to know something more.
Yes.
So, ma'am, this will be a rapid fire round and you have to answer without thinking much. So this is a rapid fire round. So, madam, you are a tea lover or coffee lover?
Yes.
You are a tea person or coffee person?
No.
The first question from there, from the lifestyle only. You will love tea or coffee?
Tea.
Tea. Okay. Madam, which is your favorite color?
It's pink color.
Pink color. Okay, very nice. And madam, which is your favorite place till now where you have visited?
Actually, India, definitely.
Okay.
Definitely India, several, there are several provinces and mostly Delhi. Kolkata is my favorite places, actually.
Okay. That's great, ma'am. Ma'am, do you want to give some message to the upcoming gynecologists by your vast experience? Everybody wants to know to become a successful doctor. So some tips if you want to share with us with the upcoming gynecologists.
Actually, the profession is the most demanding profession we go through. There is so many questions coming up, and there's one thing I want to say. Yeah, we are doctor, and when the patient is coming, there is so much sympathy or empathy is given to the patient, and also the time also given. Then the patient is satisfied and go to home with satisfaction, and their successful pregnancy outcome is coming.
Okay, thank you, madam. You can take question, Dr. Nishan, please. I'm not able to see the question note.
Yes, ma'am. Now we can see there are lots of questions. So Dr. Swati Dandu is saying this. Is there any role of torch in RPL?
Actually, in unexplained infertility, we are empirically we give an aspirin and heparin. Aspirin has many roles. It increases the blood supply, uterine blood supply, and heparin, which is also increases the blood supply, and that is thinning the blood. In that way, it causes the successful pregnancy outcome.
Then the second question is from Dr. Bina Nayak. In law resource area, without any investigation, how to treat? Should we go for polytherapy?
Thank you for nice question. Actually, in low cost treatment, we also go for empirical treatment like aspirin, like heparin. And also, if the patient is overweight, we advise her to loses the weight, especially in PCOS patient. If patient has diabetes, we advise her lifestyle modification. And so many talk we already said, the lifestyle modification is the most important factor, which is treatable cause also.
Then Dr. Vijita Reddy asking a question regarding PCOS with RPL. So how to manage it?
Thank you. Actually, PCOS, the day-to-day practice, we have many PCOS patient handle. Actually, young generation are mostly suffering from PCOS. They are taking the junk food mostly. And after that, they're coming with their menstrual irregularities, overweight, hair growth, unwanted hair growth. So we advise her actually the lifestyle modification. And if she asked me first time, second time, third time, fourth time, up to 10th time, we say her, please, you do your lifestyle modify, avoid junk food, reduce your weight, you go for daily basis exercise. After that, you come in. So if the patient is within the normal BMI between 18 to 24, automatically and normally she can conceive.
Then one more question is from Dr. Chinwe Iguilo. Can balance translocation is responsible in the male?
Most of the balance translocation are frequently seen in women, but male are also suffered from. And if the male is suffered, then advice for pre-genetic diagnosis, and after that he can go for sperm donation.
And last question we received from Dr. Mara. In unexplained pregnancy loss, is there benefit of aspirin and heparin?
Of course, there's so much role of aspirin and heparin in unexplained recurrent pregnancy loss. I previously said it increases the blood supply and thinning the blood.
Yes. So thank you, ma'am, for giving all the answers to the questions of our delegates. I hope delegates have received their answers. So, ma'am.
Yeah. Thank you, madam. Thank you so much for enlightening all of us with your immense knowledge. We are really grateful to you. So, friends, with this, we were winding off today's session. And next Thursday, I'm going to discuss with you a very important topic, the role of stress in infertility. How in these days the stress is affecting the fertility. So now what are the new studies have come up? So next Thursday, stay tuned with us. 8:30 p.m. Indian time, 5 p.m. Karyo time, 9 p.m. Bangladesh time, friends. So please catch with us on next Thursday at sharp 8:30 p.m. Indian Standard Time.
Thank you, Ritu Satani. Thank you, Nishan.
Thank you, ma'am.
Thank you, madam. Thank you once again.